Is audio video fine? Yes, all the students, very good evening. Can you update in the chat box? Is audio video fine? Very good evening. Is the screen visible, beta? So we are starting with the congenital lesion of larynx, beta. Before starting this topic, I will be just briefing you what is dyspnea, difficulty in breathing. Yes, on the other side, can you update? Is the screen visible? Is the screen visible, beta? All fine. So let us start with the congenital lesion. So beta, just the first important concept. Only left part is visible. Just wait. Well, now is audio video fine? Can we start with the session? Very sorry for this error. Let us start, beta. Is it fine now? Is audio video fine? Now I hope everything is visible to you. Yes, every student, kindly update in the chat box. So beta, we are going to discuss with, now everything is visible. Very nice. Is it visible now? Yes, visible. Now beta, let us start. Now we'll take next one hour. Next 1 hour we will be learning how to crack all the concepts of congenital dyspnea. What is the skill of cracking the MCQs of congenital dyspnea, because with this very important topic for your ENT segment, for your pediatrics. Am I understandable? In both the segment, they will be asking you all these MCQs. So let us start, beta. Yes. So then thanks a lot for showing the patience, beta. Now concentrate on the board. Congenital dyspnea. If you want, like if you have attended my lecture before, we always believe in cracking the concept in form of physics formula. So we'll be cracking all the concepts of this topic in form of formulas. Dyspnea, difficulty in breathing. Can I classify dyspnea into 3 categories? One is inspiratory dyspnea, one is expiratory dyspnea, one is biphasic dyspnea. But now concentrate on the board. Let us make a concept. First we will, yeah, every student, now focus. Now, dyspnea, difficulty in breathing, I classify into 3 categories, like inspiratory dyspnea, expiratory dyspnea, biphasic dyspnea. So before going ahead, we should have the concept how we classify dyspnea. Inspiratory dyspnea, difficulty in breathing during inspiration. Make a concept. Is the upper part. Now everyone listening to me, concentrate on the board. If there is any issue, in the supraglottic area, if there is any issue with the supraglottic area, like epiglottis, epiglottic fold, any pathology, any inflammation, any tumor, this supraglottic will fall down and will cause which dyspnea? Everybody should update in the chat box. Which type of dyspnea will be there in supraglottis or pharynx? If examiner is giving you the option. But in next 1 hour, I will be trying my best to give you all the important concepts of this topic. So let us start. You people tell me if there is inspiratory dyspnea. If there is inspiratory dyspnea, it will be supraglottic segment, supraglottic area, or you can use the word pharynx. Sometimes the examiner gives some pathology in the pharynx. It is supraglottic segment. Then this concept here. Lower respiratory tract, that is your lower part of trachea, bronchi, they have which type of dyspnea, beta? Always make a concept. Lower respiratory tract. This is the important concept. Lower respiratory tract will be having expiratory dyspnea. Why? Like my lower respiratory tract, they collapse. I am having dyspnea. During which phase of respiration they will collapse more? They will collapse more during expiration. So what is the basic funda you should develop? Supraglottic, inspiratory, lower respiratory tract, expiratory. What is left in between? In between, we are having glottic area. In between, we are having subglottic area. We are having upper part of the trachea. It means if there is any pathology, any abnormality in the glottic and subglottic area, I will be having dyspnea during inspiration or expiration. I hope you are getting my point better. Before starting this topic, this concept should be on your tips. Inspiratory, supraglottic, expiratory, lower respiratory tract, biphasic glottic area. Am I understandable? Are you getting this point? But I always highlight this point that we have to prove the things. We are not here to mug up the things better. Clear? Now question is, what is the hallmark feature of glottic segment? You tell me, which is the hallmark feature for glottic segment? Hoarseness, change in voice. In my MCQ, in my patient, if there is a change in voice, if there is a hoarseness, I will always go for glottic segment. I always go for glottic area. Am I understandable? Are you getting this point? All these concepts clear? With this basic orientation, I start the topic of dyspnea, congenital dyspnea, but question is, how can you decide hoarseness in a newborn? We are discussing with the topic of congenital dyspnea. Any student who can tell me how you will decide dyspnea in a newborn, we will focus on the cry of the child. Just remember this point. Clear? So if the cry of a newborn is normal, if cry is normal, I am going to rule out. If cry is normal, I am going to rule out glottic segment. Just make this concept. Am I understandable? Clear? Now from here, let us go to the next level. After learning all these points, we classify the congenital lesion into these categories: laryngomalacia, congenital webs, subglottic stenosis, hemangiomas, cleft, laryngocele, laryngeal cyst, and vocal cord paralysis. Because these are the important differential diagnosis for congenital lesion of the larynx. Little bit difficult topic, but what is the motive of taking this topic in this session? To give you a message ki how to crack these difficult topics. So better let us start. Everybody actually participate. Laryngomalacia, congenital webs, subglottic stenosis, hemangioma. Now I will divide this topic in two parts. Now concentrate on the board, beta. Every student, we will divide this differential diagnosis into upper half. What is upper? Laryngomalacia. At which level? It is supraglottic level. Just remember this point. So before starting the formal topic, we are just making some formulas. First, we have learned dyspnea, type of dyspnea, all those points. Now what I am doing, we're not here to mug up the whole list. We're not here to make any mnemonics of this list, not at all. We will prove these things. Laryngomalacia is equal to supraglottic. Laryngeal web. If examiner asks you me laryngeal web, anyone, any student in the chat box, can you tell me whether laryngeal web is at which level? Laryngeal web is at which level? Anyone, any student? It is at the level of glottic area. It is at the level of glottic area. Am I understandable? Congenital, the word itself is telling you subglottic. I am at the level of subglottic. This is your subglottic area. This is at the level of subglottic area. Actually participate with me, beta. Subglottic hemangioma. These two conditions are at the level of subglottic area. Very good. Very nice. Yes, beta, doctor. So remember, anterior commissure. One of the student is even mentioning this point. At which part of the glottic area. We will go to that level in the next couple of minutes. First, learn the concept. I divide these 8 differential into upper 4. What are the upper 4? One for the supraglottis, laryngomalacia in the examination hall. Glottic, so congenital web. So subglottic. I'm a DAMS student. So 2 points come in my mind. One is subglottic stenosis. One is hemangioma. Done. Now, the next condition is laryngoesophageal cleft. One is laryngocele, laryngeal cyst, and congenital vocal cord paralysis, which is very rare. Now concentrate on the board. Laryngotracheoesophageal cleft. It is a congenital anomaly. It is a congenital anomaly of larynx plus trachea plus esophagus. So my formula will be laryngotracheoesophageal cleft is equal to larynx plus trachea plus esophagus. I hope you are getting my methodology, what method I am using, beta. I am first giving you the formula dyspnea, type of dyspnea we have learned. Then we are classifying the topic depending on supraglottic, glottic, subglottic. If you remember, if you attend my audiometry, what I do? I make the concepts of audiometry, then we apply on different topics of here. Same what I am doing here now. I am classifying the topic, then I will apply the concept of destiny on these topics. I'm repeating again and again, beta. Revise with me. Supraglottic, every student sitting listening to me. Laryngomalacia, supraglottic, subglottic, surveps. Subglottic areas are two conditions. One is stenosis, one is hemangiomas. Now coming on the rare condition, laryngotracheoesophageal cleft. Larynx plus trachea plus esophagus is involved. Here is my smart student. What my smart student say? Sir, larynx involved, trachea involved, sir, esophagus involved. Sir, can I make a formula? This patient must be having aspiration. Absolutely yes. What will be the prominent symptom of laryngotracheoesophageal cleft? One smart student say, sir, the esophagus, trachea involved. It means there is aspiration. I hope you are getting my point. Now coming on the next segment. Now concentrate on the board, beta. Make this concept. Laryngocele and laryngeal cyst. These two conditions are in supraglottic area. This is a often repeated MCQ. Laryngocele. What is the most common site? Anterior half of supraglottis. So what the concept I'm making here? I'm making a formula. Laryngocele is equal to anterior part of supraglottic area. Anterior part of supraglottic area. Done. Laryngeal cyst. Any student who can tell me most common site for laryngeal cyst? Most common site for laryngeal cyst is here aryepiglottic fold. Aryepiglottic fold. Aryepiglottic fold. Thanks for all these students for responding in the chat box. But this is something interactive session. What we are giving you. You should interact with the faculty. You should raise the query. You should learn the methodology. Congenital vocal cord paralysis is very rare. It means one day before your NEET examination, this type of diagram should be in front of your mind. So I divide supraglottic, glottic, or supraglottic. They will be either ask me the most common congenital anomaly. I will be repeating again, but I will be repeating all these concepts. First, make the basic diagram. The supraglottic segment. What is the most common congenital anomaly of larynx? Laryngocele. The first concept. Now we are, for the next couple of minutes, in next 1 hour, we will crack this topic to the core. We will crack this topic so that we can revise it properly. And at the last, I will make you mind map of this topic so that you can revise very comfortably. I'm understanding. What is the motive? We will learn the topic. We will concise the topic, and then we will make some mind map. We concise on a single page. I'm understandable. Supraglottic, most common congenital. What are the rare condition? So my DAMS students will write rare condition. So rare condition will be either laryngeal cyst. What is the most common site for laryngeal cyst? Sir, we know it is aryepiglottic fold. Yes, agreed. Or it can be laryngocele. Laryngocele. Done. I hope you are getting my point. Sir, what is at the level of glottic area? So glottic area, we are having webs. Where? Which part of the glottic area? So we are having webs at anterior part of the glottic area. Very simple. So subglottic area. So subglottic area, we are having two conditions. One is hemangiomas and one is here stenosis. One is stenosis. I hope you are getting the message. Laryngocele, congenital webs, hemangiomas and stenosis. Vocal cord paralysis is one of the rare condition. Vocal cord paralysis, one of the rare condition that we will not discuss here in this long list. Then at the last, there is laryngotracheoesophageal cleft, for which what is a keyword? Keyword we have read. Keyword we have read is here aspiration. Here the patient will be must be having aspiration. I hope you are getting the message. We are dividing the whole larynx, upper part, laryngocele. Revise with me, beta. In the class only, we will revise all these points. Upper part, laryngocele. Most common, laryngocele in a newborn. All these students preparing for Central Institute, highlight this point. Newborn. Sometimes the examiner give you -1 by writing the word infant. If I am talking about newborn, I will be going for laryngocele. Laryngocele. Which are the rare condition? These are the rare condition. I hope you're getting them. Okay. Am I understandable? Are you getting this point? Now, can I ask you one image-based MCQ? Let's see who reply first, beta. After making this long list, I magnify the slide for you. I'm asking a query. This is a membrane shown to you. This is a membrane. Which membrane, sir? I have a label. Thyroid membrane. Let's see who reply first. This membrane is ruptured. This membrane is ruptured by which of the following condition? Any student who can reply? Out of these 8 conditions, 7 to 8 conditions of congenital dyspnea, can you tell me thyrohyoid membrane is ruptured by? Let's see who reply first, beta. I'm waiting for a response in the chat box. Yes, anyone? Absolutely. Dr. Divya, excellent. Laryngocele. This laryngocele, beta, this laryngocele rupture the thyroid membrane. We'll discuss in detail. It is laryngocele. Dr. Divya Vinayak, excellent. Very good. It's very fast reply. Now, many students must be knowing here this is ruptured by. But if the examiner make a image-based MCQ, they give you this slide, they make a arrow, they ask you the given. Secular says no. It is laryngocele word will be the better, beta. Dr. Rachana, laryngocele will be the better option. Done. After learning this, what we have done, we have learned the sites of the lesion. We have learned the symptomatology. Inspiratory dyspnea, biphasic expiratory. Now we will apply these concepts. Let us start. The first topic, the patient enter. This is a endoscopic view of larynx. What is my normal epiglottis? You tell me. Normal epiglottis. Normal epiglottis is like this. This epiglottis is very weak. This epiglottis, this supraglottis is very weak, very soft. Ortho people use a word osteomalacia. I copy the word malacia. I make this term laryngomalacia. What is laryngomalacia? Is the weakening of the supraglottis. I hope you're getting my point. What I'm showing you, this is omega shape epiglottis. Very good. Omega shape epiglottis. This is my omega shape epiglottis. Very good. Everybody should actually participate. Now apply the concept. Which type of dyspnea? Sir, it is supraglottis. So which dyspnea? My smart student will say, sir, I will apply the concept. Inspiratory dyspnea. Agreed. Every student, inspiratory dyspnea. But just remember, all the interns, post-interns going for your Central Institute, beta, they can confuse you by writing the word infant. Most common congenital anomaly in a newborn is laryngomalacia. Inspiratory dyspnea. Close your eyes and tell me this dyspnea will increase during which phase, will decrease in which condition. It will increase and decrease. Let us make a nice concept. If the child is crying or on feeding, which are the 2 conditions on which the inspiratory dyspnea will increase? You just do imagination. Epiglottis, supraglottis is weak, is very weak, very immature, is floppy, is falling down. So during cry or during feeding, the inspiratory dyspnea increases. And now do imagination in which position the dyspnea will decrease. It will decrease in prone position. Those students who are listening me first time, learn the concept beta. Just do imagination, newborn, epiglottis falling down. So when the newborn is in a supine position, the epiglottis will fall more. So patient will be having more dyspnea. But in a prone position, the epiglottis will again fall. Definitely the epiglottis will fall, but it will fall anteriorly. Because it fall anteriorly, the dyspnea resolve. So the concept, the golden statement is inspiratory dyspnea increase during feeding, increase during crying, but decrease during prone position. Kindly thumbs up in the chat box if you get this concept. Why the inspiratory dyspnea decrease in prone position? Everybody comfortable with this concept? Inspiratory dyspnea increases during feeding, cry, and decreasing during prone position. That any student who can comment on the hoarseness, change in voice component. So it is a supraglottic. What we have learned. So we made a concept. Change in voice is a hallmark feature of glottic area. Because it is a glottic area, hoarseness will never be seen. How can you judge hoarseness in a newborn? We can judge hoarseness in a newborn by cry is a normal cry. Clear? Is a normal cry. In this child, the cry will be normal. Dr. Rachana, beta, newborn and infant concept is, even in my T&D I have given this question. Most common congenital anomaly in a newborn is laryngomalacia. Sometimes the examiner confuse you by writing the word infant. In that case, it is subglottic cyst, beta. Subglottic cysts are commonly seen. Most common. Laryngomalacia will resolve by 2 weeks. Therefore, if the examiner is using the word infant, then I will be going for subglottic cyst. I hope you are getting this point. This was one old MCQ. Which of the following is not true about laryngomalacia? Omega shape epiglottis. Absolutely true statement. But now we will add few points. Omega shaped epiglottis is a hallmark feature. Omega shaped epiglottis is a hallmark feature of laryngomalacia, but can be normal. Everybody add in the notes, omega shaped epiglottis may be normal, may be a normal finding, may be a normal finding. Standard increase on crying but decrease in placing a prone position, absolutely true. Most common congenital anomaly of a larynx, true. Surgical management of the airway by tracheostomy is the initial, not at all, is not the initial. Why? What is the initial treatment? What is the first line of treatment of laryngomalacia? Beta, newborn. Newborn is very comfortable. Newborn is asymptomatic. Always remember. Because newborn is asymptomatic, what is the treatment? Wait and watch. This image will help you in the examination hall. Laryngomalacia, most of the cases are asymptomatic. Because they are asymptomatic, wait and watch is the treatment. I hope you are getting this point. Very good, everyone. Dr. Divya, excellent, excellent. 90% of the cases, 90% of the cases improve by 2 weeks, and all the cases improve by 2 years. Therefore, never make the diagnosis beyond 2 years. What is the golden rule? Golden rule is, in laryngomalacia, never make the diagnosis beyond 2 years. Done. Exceptions are always there. Patient may have dyspnea. We have to decide the treatment. But most of the cases resolve by 2 weeks and all the cases by 2 years. Therefore, we never make the diagnosis beyond 2 years. Now question is, exception always prove the rule. If the newborn is having dyspnea, what will be the treatment, sir? Common sense. Just apply the logic. Whenever we repair something, which word is used for repair? Plasty. It means I will use the word supraglottoplasty. I will be repairing the supraglottis. Supraglottoplasty. I can use the word epiglottoplasty, or we can do tracheostomy. Just remember these points, which are the surgical intervention in a patient, in a newborn having severe dyspnea. So exceptions are there. If laryngomalacia patient have some dyspnea, we'll go for supraglottoplasty, epiglottoplasty, or tracheostomy. This is the first condition that we are discussing, is your laryngomalacia. Now, what I'm showing you between right and left vocal cord, sir, I am appreciating a fibrous band. What is this fibrous band? This fibrous band is congenital webs. We label it as congenital webs. What is the most common site for congenital webs? Is your glottic area, is glottic segment, is your glottic area. Done. Which part of the glottic area? So here we will build a concept. Vocal cord is anteriorly attached with the thyroid. Posteriorly they are attached with the arytenoid. And this anterior commissure, this anterior attachment is anterior commissure. Just remember, anterior commissure is rarely involved. Any student who can tell me why anterior commissure, why the anterior part of the glottic is rarely used? Yes, any student? Yes, let's take one query. Can we, I'm not with up. Please kindly write what you want to ask. Yes, anyone? Yes, can we mention it as glottic? No, beta. No. We are dealing with webs now. No. Can we mention it as rima glottis here? Absolutely true. Very nice, beta. But the student is saying, can I use the word rima glottis? Yes. What is rima glottis? A space between the right and the left. Absolutely right, beta. Absolutely right. It is a rima glottic segment. Then now concentrate on the book. Anterior, any student who can tell me why anterior commissure is not involved? Anterior commissure is commonly protected area. Who is protecting? This epiglottis. Epiglottis is protecting your anterior commissure. Therefore, anterior commissure is rarely involved. All the students going for Central Institute, just remember on this side, I'm making a concept for you. Anterior commissure is rarely involved, except two conditions, except 2 points. The examiner asks you 2 important points. One is congenital webs, one is papillomatosis. Just remember, Antecommissure, beta, build up this concept. Antecommissure is rarely involved. Antecommissure is rarely involved, except congenital webs and papillomatosis. These conditions are on the anterior commissure. These conditions are on the antecommissure. That it is on the glottic area. Because it is glottic area, you apply the logic. You apply the common sense. It is on the glottic area, so it will be biphasic dyspnea. The newborn will be having dyspnea during inspiration as well as expiration. It will be biphasic dyspnea. Agreed. Now make one more formula like physics. The patient will have abnormal cry. So what is the hallmark feature of this condition? Hallmark feature of this condition is abnormal cry. Then biphasic dyspnea, abnormal cry. Clear? Which classification I am using in this patient? Always remember, we use Cohen's classification. This is an old MCQ. This is an important PYQ beta. And again, before going ahead, I just want to give you one concept. Instead of going for the quantitative learning, I'm just discussing multiple hours on congenital. No better, just go for PYQs. But I always say, concise notes. Your concise notes should be very concise, in 10 to 15 pages. 15 pages maximum. My ENT should be in 15 pages plus last year PYQ plus DVT. But this is the minimum thing which we have to do. Beyond this, if we have time, if we have revised multiple times, then if I want to do anything, you can. But what is the minimum thing? Concise notes, last 3 years PYQs, previous year questions, topics should be on your tips, and DVT. Little concise, revise them, because we have ample time now, because we are going for your next NEET examination, beta. This is the minimum thing. Now after this, you are having ample time. You go do anything, whatever you want. But before that, just make a promise in the chat box, beta. First, we will focus on these 3 things: concise notes, PYQ, DVT. इसके बाद बेटा टाइम बचता है, जो मन करे करो आप. It's your right. But this is the minimum thing. It should not happen कि सर मैंने लास्ट ईयर का क्वेश्चन करा नहीं, लास्ट का 2021 क्वेश्चन मैंने टच नहीं किया. बेटा क्वेश्चन कैन बी डायरेक्टली फ्रॉम योर ओल्ड नीट पेपर. सो जस्ट एटलीस्ट PYQ, PYT should be on your tips. Cotton Wear, no beta, no. Dr. Rachana, it is not Cotton Wear. Dr. Energy is not Cotton Wear. Cotton Wear classification is used for subglottic stenosis. Here I am using Cohen's classification. Cohen's classification, we have 4 types: type 1, type 2, type 3, type 4. Always remember. Type 1. What is type 1? Type 1 is mild. This is based on 2 important findings. One is your hoarseness, one is dyspnea. So in type 1, grade 1, some books use the word grade 1, type 1. In grade 1, there is mild hoarseness, but there is no dyspnea. Grade 2, it is moderate hoarseness, moderate change in the voice with mild dyspnea. In grade 3, it is your severe hoarseness. And grade 4, it is complete loss of voice. And grade 3, there is moderate dyspnea, and finally is your severe dyspnea. This is the basic classification, what we call it as COHEN, Cohen's classification. But remember this one, Cotton Wear classification. Cotton Wear classification is for subglottic stenosis. Cohen's classification is for congenital webs. Is it clear, beta? Cohen's classification. Coming back, what is the treatment of choice? CO2 laser. Make a concept. ENT, we prefer CO2 laser. Then in ENT, we are preferring CO2 laser. Now I remove the fibrous band. This is my vocal cord rima glottis. This is my fibrous band. Now when I remove the fibrous band, there are some raw areas, beta. These raw areas will again touch each other, will lead to fibrosis, adhesion. So what we people do, we always put a small device. I will put a small device here, which is known as celestic keel. So this celestic keel, why this celestic keel is used? To reduce the chances of reoccurrence. To reduce the chance of reoccurrence, we use celestic keel. Then is it clear? I'm sharing you a nice important flowchart. Let us revise this flowchart in a nice way. If the newborn is asymptomatic, we'll go for wait and watch. Absolutely yes, wait and watch. If patient is having symptoms, we can go for excision with the help of CO2 laser, or celestic keel will be used in thick webs. Always remember, they can make one MCQ. Celestic keel is mainly used in most of the newborn, not at all. In thin webs, no. Thick webs. If the web is very thick, there is high probability that it will reoccur. So always remember this point. Celestic keel is used for thick webs. Then, am I understandable? Are you getting this point? Coming to the next slide, what I am showing you now. Focus your eyes on the book. We have discussed one pathology from the supraglottis, one from the glottic area. Now concentrate. I'm in the supraglottis, then I'm in the glottis. Now I'm going below glottis. What is below glottis? It's a subglottic area. What is there in the subglottic area? What was the expected diameter of subglottic area? Expected diameter of subglottic area was this one. But now what I'm observing, this is endoscopic view, I'm seeing the subglottic area is very small. Now focus your eyes on this area. This is subglottic, very narrow space, very narrow subglottic area. Therefore, we are discussing now why we label this patient as congenital stenosis. Congenital stenosis. What is the most common site for congenital stenosis? Subglottic area. Make a formula with me. So which symptom will be there? You people tell me. It is absolutely better. There is a chance. All these are the complication. All these are complication. Injury to the nerve, injury to the area, reoccurrence. All these are complication. Can you tell me in the chat box? It is subglottic stenosis. If it is subglottic stenosis, what will be the formula for the symptom? Subglottic area. It will be biphasic dyspnea. It will be biphasic dyspnea. But cry will be normal. Every student, what we have learned, cry is a hallmark feature. Abnormal cry, change in voice is a feature of glottic area. We are working in subglottic area. It will be your normal cry. It will be normal cry. Done. Subglottic stenosis. Which classification is used? Just remember, we use Cotton-Mayer classification. Beta. Here I am using a Cotton-Mayer classification. What is Cotton-Mayer classification? Grade 1, grade 2, grade 3, grade 4. Revise with me the whole topic. Beta. In this 1 hour, we are discussing the whole concept of congenital dyspnea. What is the differential diagnosis? You can write all these points in short note if any third year student listening to me. Cotton-Mayer classification, less than 50% is grade 1. Less than 50% grade 1. 51 to 70% is grade 2. 71 to 99% is grade 3. And if there is a total obstruction, it is your grade 4. Is your grade 4. Done. Now, what is the treatment? Treatment, there is a stenotic area. There is a stenotic segment. So what we will do? So I will go for excision and re-anastomosis. Excision and re-anastomosis. Now you people reply. Every student listening to me. What is the basic concept? I am having two approaches. One is endoscopic approach. One is open approach. Yes, one is endoscopic approach. One is open approach. You tell me which approach is preferred in early, which approach will be preferred in the late scenario. Yes, very early stage. In the early stage, you tell me. Early stage beta will be going for small lesion, endoscopic. In the late, if the lesion is very severe, late scenario, I will go for open approach. I hope you are getting the concept. Out of these 4 grades, can you label which 2 grades can be considered as early? Sir, grade 1, grade 2 can be labeled as early. I will prefer endoscopic approach. Grade 3, grade 4, I prefer open approach. Everyone kindly. Yes, any query, please update in the chat box. But this is the best platform where we are interacting. Any query, any point you want to me discuss, want me to repeat, please update in the chat box. So endoscopic view. Endoscopic view is for early grade 1, grade 2. Open is for grade 3, grade 4. Done. Is this everybody comfortable with this one? Now, what is the definition of subglottic stenosis? Very important MCQ. Subglottic stenosis is defined as diameter less than. You tell me what is the diameter less than? Subglottic stenosis is less than 3 mm or less than 4 mm? Anyone who can update in chat box, beta, is less than 3 mm or less than 4 mm? Preterm baby, full term baby. F for full, F for 4. Just remember, full term baby, it is less than 4 mm. In a preterm baby, it is less than 3 mm. I am asking you preterm baby. What is the right answer? Less than 3 mm. In preterm baby, it is less than 3 mm. In full term, is less than 4 mm. Is it clear, beta? Is it clear? Comfortable? Coming to the next one. What I am showing you. Very important concept. Everybody should write with me. Reddish mass, red mass in subglottic area. In ENT, if you're going for NEET examination, two important differential diagnoses: red mass in subglottic area or red mass behind tympanic membrane. Any student who can tell me what is A, what is B? Any student who can update in the chat box, beta, what is A, what is B? What is A, what is B? Reddish mass in subglottic area. Reddish mass in subglottic area is your hemangioma. What is A? A is hemangiomas, congenital hemangiomas. What is B? Behind tympanic membrane. It is behind tympanic membrane. Glomus tumor is glomus tumor. So two important points: reddish mass in subglottic area. Subglottic area is hemangiomas. Behind tympanic membrane is your glomus tumor. Is your glomus tumor. Done. This reddish mass. What is the important concept? Hemangiomas, glomus tumor. We will not be going for biopsy. We will not go for biopsy. One important concept. In hemangiomas, now concentrate on the board. In hemangiomas, we do surgery. Yes, what is the treatment of choice? Surgical excision. We go for steroids to reduce the size of the tumor. I can go for antiviral interferon to reduce the size of the tumor. We can use CO2 laser. Any student who can update in the chat box what not to be done. All these are part of treatment, part of management. Any student who can write in the chat box what is not to be done, not to be done in this patient. In hemangiomas, what we avoid radiotherapy. Make this concept. In subglottic hemangiomas, we avoid radiotherapy. Clear? That clear? It reduces the immunity of the child, which lead to proliferation of the tumor. Therefore, we avoid your radiotherapy. Coming to the next one. Rare conditions. After learning the most common conditions, laryngomalacia, congenital webs, subglottic stenosis, I'm taking you to the laryngotracheoesophageal cleft. So beta, there is larynx, this is trachea, this is pharynx, esophagus. Here comes the importance of line diagrams, beta. Whenever you learn the things, always make a habit of drawing something. Always make a habit of making some line diagram. It helps a lot. Larynx, trachea. Who is the boundary of larynx and trachea? Beta, this area. This is my cricoid. Done. So deciding factor in this topic is cricoid. I have one classification was there with the name of Benjamin classification. What Benjamin say? It divide into 4 types. Type 1, type 2, type 3, type 4. Now listen carefully. A Benjamin classification little bit difficult, but we will try to make it simplify for you. What is Benjamin classification? Type 1. Type 1 is there is a pathology only in the upper part. Supraglottic cleft. Supraglottic cleft with normal cricoid. Always remember, cricoid is normal. But we will revise in the class only. The best part of concise notes, you get ample time to revise. Type 1 is supraglottic cleft with normal cricoid. Beta, समझ में आ रहा है? Normal cricoid. What is grade 2? Grade 2 is grade 1 with partial cricoid involvement. Partial cricoid involvement. What is grade 3? Is grade 2 plus complete cricoid involvement. There is complete cricoid involvement. Revise with me. Grade 1, type 1. supraglottic cleft with normal cricoid. Grade 2, partial cricoid. Grade 3 is total cricoid. And what involvement? Maldevelopment. Grade 4 is grade 3 plus even thoracic trachea is involved. Thoracic trachea is involved. Now, one of my students say, sir, what about the cervical trachea? So just remember, cervical trachea plus minus maybe may not be involved in type 3. Type 3 may not be involved in type 3. Revise with me in the class itself. Type 1. What is type 1? Supraglottic cleft. Supraglottic cleft with normal cricoid. Type 2 is supraglottic cleft with partial cricoid involvement. Type 3 total complete cricoid. And last is your thoracic trachea is involved. Now listen carefully. Now concentrate on the board, every student. Type 1, here I will be writing one formula for you. Type 1 is your asymptomatic. Therefore, we prefer to wait and watch. Clear? In type 1, it is asymptomatic. Therefore, wait and watch. In type 2 and type 3, in type 2, type 3, we have to repair the larynx, repair of larynx. We will approach the larynx. Either we go for larynx, laryngotomy, or we can go for pharynx, pharyngotomy. We use the word laryngotomy or pharyngotomy. We have to use one approach out of these two. Either laryngotomy or lateral pharyngotomy. We use either of these two approaches. And grade 4, we have to repair the thoracic trachea. So it is here repair of the larynx plus thoracic trachea. I hope you are getting the concept better. This is something laryngotracheoesophageal cleft. I am showing you a endoscopic view. Again, what will be the prime symptom of this patient? Prime symptom of this patient will be aspiration. Aspiration. Done. Coming to the next segment after learning all these basic points. Vocal cord paralysis is a very rare topic, rare condition. Vocal cord paralysis, congenital vocal cord palsy, at birth it can be idiopathic, it can be traumatic. Clear? Vocal cord paralysis, just make a basic funda, is a very conceptual topic and one of my favorite topic. But like we are discussing in the congenital dyspnea, in this segment, I want to give you a important concept. Just remember, beta, vocal cord paralysis, just make a concept if it is unilateral recurrent nerve palsy, unilateral superior laryngeal nerve palsy. Always remember, in unilateral palsies, it is wait and watch. Any student who can write in the chat box why it is wait and watch in unilateral cases. Any student, I'm waiting for response, beta. Why in case of unilateral vocal cord paralysis we prefer to wait and watch? Because commonly, what is a common symptom is only hoarseness, change in voice. But surgical intervention is always required for bilateral cases. Surgical intervention is required for bilateral recurrent nerve palsy or superior nerve palsy. Here you should have a concept. In case of bilateral recurrent nerve palsy, patient have severe dyspnea. In case of bilateral superior laryngeal nerve palsy, patient will be having complete loss of voice and aspiration. Complete loss of voice and aspiration. Done. Is this clear, beta? Is everyone clear? Crystal clear? All these concepts? Can you update in the chat box, beta? Is audio, video, everything fine? All these concepts clear? Therefore, we go for surgical intervention, and then examiner can confuse you by writing bilateral recurrent nerve palsy. If bilateral recurrent nerve palsy, vocal cord are in the midline. Because vocal cord are in the midline, any student who can write what is the other name of bilateral recurrent nerve palsy, bilateral vocal cord are in the midline, we use a word abductor palsy. Just remember this point, ABD, abductor palsy. Done. Is this clear? Abductor palsy. Is this clear, beta? And if it is superior laryngeal nerve palsy, just remember this point. If it is superior laryngeal nerve palsy, any student who can tell me superior, bilateral superior laryngeal nerve palsy, what will be the common symptom? Bilateral superior laryngeal nerve palsy, bilateral superior laryngeal nerve palsy, it will be adductor palsy. It is adductor palsy. Very good, very nice, Dr. Sahil. Excellent, excellent. This is a rare condition. Very rare. Congenital dyspnea is a rare. Congenital vocal cord palsy is a rare cause, but all these points should be on your tips, beta. Clear? Recurrent nerve palsy. Again, I am repeating, vocal cord are in the midline. Therefore, we use the word abductor palsy because vocal cord are in the midline. Both the vocal cord are near to each other. Yes, Dr. Sahil, excellent. Dr. Nitish, very good, beta. Absolutely yes. What will be the treatment? Treatment will be lateralization. The treatment will be all the procedure of lateralization. While in superior laryngeal nerve palsy, where there is adductor palsy, it will be medialization. It will be all the concepts of medialization. I hope all these concepts clear. Done. Coming to the next level, what I am showing you. This is a endoscopic view of laryngeal cyst. Laryngeal cyst. What is the most common site? We have already learned area epiglottic fold. It is surgical exam. Area epiglottic fold, subglottic area. These are the important. So what will be my formula? My formula will be laryngeal cyst is equal to area epiglottic fold is equal to surgical exam. Very nice. Everybody is writing. Even the operation, Kashima surgery, Kashima operation. Very nice, beta. Excellent, excellent. It means the whole topic is on your tips. You revise it properly. Clear? This is my laryngeal cyst. Done. Coming to the last segment. Now concentrate on the board. What is the concept of laryngocele? Now we will crack the next segment, laryngocele. Remember, I always say in my lectures a mnemonic of T square. Like physics, we are cracking all the concepts. T square. One T stand for trumpet player. Everybody should highlight this point. It is in trumpet player or trumpet, a long musical instrument you must have seen in marriage functions. So trumpet player and rupture of one is trumpet player. One is rupture of which membrane? Thyrohyoid membrane. Thyrohyoid membrane. So when you are going for your NEET examination or Central Institute beta, they are concerned about 2 points. अब देखो, ये तो smart student. अगर laryngocele पे question आए, so either he will be asking you, he will be giving you a clue of trumpet player, and they will ask you what is the which membrane is ruptured. These are the 2 points. Either they will give you this as a clue, or they will give you the clue of thyroid membrane. Beta, किसी भी MCQ में, in any MCQ, if they mention this word, a air-filled cavity rupturing the thyroid membrane, or they show you some image where thyroid membrane discontinuity, there is some rupture of the membrane, go for laryngocele. I hope you are getting my point. Very nice. Dr. Nitish is updating trumpet player. Now, what is the pathophysiology? I will draw with the help of line diagram. The beauty of when you attend my ENT lecture, I always say keyword and line diagram. These are the 2 things which give you a decent trend. This is my cricoid, this is my thyroid, this is arytenoid, which is anterior, so this is anterior, this is posterior, this is thyroid membrane, epiglottis. Now what God has gifted you, a very small pouch. What is this pouch? Anyone who can write in the chat box. This small pouch is known as saccule. Beta everyone, this small pouch is known as saccule. In this small pouch, there is maximum density of mucus gland. And this pouch come down, this slip of tongue, this mucus come down and it lubricate the vocal cords. So what is the function? So can I call this saccule as oil tank of the larynx? Yes, absolutely. We use a word. Oil tank of the larynx for saccule. Now this saccule is blocked. When this saccule is blocked, it is converted to saccular cyst. And if the size of the cyst go on increasing, if the size increases, we call it as laryngocele. I hope you are getting my point, beta. This is a air-filled cavity, air-filled swelling. I will write a formula. It is air-filled cavity. The air-filled cavity. Now this laryngosele cannot rupture. It cannot rupture this thyroid cartilage. It day by day, it go on increasing the size and it will rupture your thyroid membrane. Once it rupture the membrane, it comes out. Once it come out, it is extrinsic. If it is inside, it is intrinsic. Are you getting this concept, beta? If this swelling is outside the membrane, it is extrinsic. If it is inside the membrane, that is intrinsic. Rupture of this membrane convert intrinsic to extrinsic. What is the symptom? It is a supraglottic swelling. So you will label it as inspiratory dyspnea. But it is supraglottic swelling, inspiratory dyspnea with this is the only one segment where I'm having change in voice. Can you tell me, any student who can write in the chat box, why this patient will have change in voice? Anyone? Any student who can write in the chat box? Yes, any student who can write in the chat box, beta, why this patient will have, yes, anyone? Why this patient will be having hoarseness? This patient will have hoarseness because pressure symptom, because of lack of mucus. So this patient will be having hoarseness because of lack of mucus. Now one of the query, one of the student is saying, saccule from the inferior border of pre-epiglottic space. Beta, you are going to the next level. Very good, very nice. One of the student, dekho beta, listen carefully. Your NEET examiner will ask you laryngosele is in the anterior part or posterior part. This is often repeated MCQ. Laryngosele is in the anterior half or posterior half. Diagram is clearly proving it is in the anterior half, not in the posterior half. This is what they are expecting. Now one student going one step ahead. One student is saying, okay, sir, can I write one statement? My laryngosele is inferior to pre-epiglottic space. Very good. Now what you are doing? You are combining your anatomy with a clinical segment. What is pre-epiglottic space? So this area is my pre-epiglottic space. So now one student is writing saccule is forming inferior border. Yes, saccule is not making the inferior border, it is below. Saccule is somewhere beta here. Saccule is at this level. Now listen to this student query. The student is saying saccule is below pre-epiglottic space. This is my pre-epiglottic space. Below pre-epiglottic space is saccule. Agreed. Laryngosele, in the early stage, laryngosele is inferior to pre-epiglottic space. And then it is, as the size increases, it will reach the level of pre-epiglottic space. I hope you're getting my point. Saccule is always inferior to pre-epiglottic space. Seems to be true statement. But laryngosele, when the size of the laryngosele will be big, large, it will be somewhere at the level of pre-epiglottic space. I hope you're getting the message. So what is the symptom? Symptom will be inspiratory dyspnea with hoarseness. Why hoarseness is there in this patient? Because the patient pressure symptom, lack of mucus. Absolutely right. What is the treatment? Surgical excision. Treatment will be surgical excision. So in any of the MCQ, if they show you trumpet player, they show you rupture of thyroid membrane, we go in the favor of laryngosele, air-filled cavity. Because it is air-filled cavity, examiner can use a word radiolucent. Clear? Swelling in the vicinity of thyroid membrane. Because it is full of air, it go up, it move up, it ascend up. It rupture which membrane? Cricothyroid membrane? No sir, it is cricothyroid. Where is the cricothyroid? Cricothyroid is below. It is going above. It is thyroid membrane. What is the symptom? Symptom will be supraglottic, inspiratory, but change in voice can be there. Done. It is because of pressure symptom. Done. Is this clear, beta? Everything, every concept clear, crystal clear? So these are the important causes. Now, before winding up the session, can we make it okay? This is the first step. You have attended the session. You made notes with me. Now everything is with you. Now what is next step? I will revise it 2 times, beta. When we will revise all these concepts nicely, after revising things, you will make a mind map. What this is congenital. Every student do this exercise with me, beta. Congenital dyspnea. I will classify into supraglottic area, I will classify into glottic segment, I will classify into subglottic, and the fourth will be rare. This will be rare. I am teaching you how to concise your notes. So supraglottic. Again, supraglottic most common is your laryngomalacia. Appreciate this methodology. My motive of conducting this session for you people. Laryngomalacia, so bracket is equal to most common is equal to supraglottic segment is equal to inspiratory dyspnea, increase on feeding. I will write first alphabet feeding, increase on cry, decrease on prone position, asymptomatic. Therefore, wait and watch. Done. I hope you are getting the message. Beta. We are writing the keyword. All these are the important keywords. Rarely we require tracheostomy. Even if you don't remember your 10%, your 2 weeks maximum 90% respond, all the cases respond by 2 years. Nobody's tracheostomy done. These are the important key. What is the other things on the supraglottic segment we have read? One is area epiglottic fold, laryngeal cyst, or we can write laryngocele. Glottic area is equal to webs. Glottic area webs is equal to biphasic dyspnea is equal to abnormal cry is equal to Cohen's classification is equal to CO2 laser is equal to celastic web. I hope you are getting my celastic key to avoid webs. One day before the examination, beta, you can afford only this thing. Glottic area. Are you loving this, beta? Are you loving this mind map? After learning the whole concept, we are trying to concise everything. Webs is equal to biphasic is equal to abnormal cry is Cohen's classification is CO2 laser is celastic. Subglottic stenosis is equal to less than 3 mm with no need of writing pre-term, full term, then 4 mm, then cotton wear classification, then grade 1, grade 2, grade 3, grade 4 should be on your tips. Biphasic dyspnea with your normal voice, normal cry. Treatment surgical excision. This is what we have read. What is the rare finding of subglottic area? Sir, we can discuss hemangiomas. In subglottic segment. What to be done? Given surgery, CO2 laser, everything, but surgery, radio avoided. Radio will not in this patient. Then vocal cord paralysis. Important causes of vocal cord paralysis. What is unilateral cases? We always go for wait and watch. And bilateral conditions, we go for surgical intervention. I hope you're getting the message. But it's something this we have to do. This is ultra concise method. Now, if we have this complete mind map of congenital dyspnea, I can revise it multiple times. Yes, kindly update in the chat box, beta. Are you loving all these points? Every student? Any query from your side, beta? This was my motive of conducting this session, to give you the insight of this congenital dyspnea, and at the last, how to concise the notes in a systematic way. Beta, now just what is again, I am repeating all these basic points. Our target is to do smart learning. We are born to do smart learning. Try your best to concise your notes. Unless we will not concise the topic, it will not be possible for us to revise again and again. I hope you are getting my point, beta. Just try to make concise notes. I'm giving you one target, all short subjects, beta, like ENT. I'm giving you one target. The day you concise ENT, in 15 pages, you will manage to revise it multiple times. Honestly, I'm telling you, beta, don't make the things complex. Simplify the things. Take the keyword. You're not here to do PhD of the topic, beta. When you will join ENT as a post-graduation, you spend next 3 years to do mastery of all these points. But now you should only concentrate on keywords. Only concentrate on the keyword. Every student comfortable? Concise the notes. Focus more on the revision, beta. Focus more on the revision part. Many students, they say, sir, I forget the things. Beta, forgetting the thing is a normal phenomena. Unless you will not revise 4 to 5 times, it will not click in the examination hall. It will not click in the exam. Revise multiple times. Am understandable? Clear? Again, before sleep, just revise. Try your best to make this mind map. Try to make this mind map of congenital dyspnea. Any query, feel free to ask me. You can inbox me, you can write in the Telegram group. Just try your best to concise this topic, revise before sleep, beta. Yes. All the students who are preparing for upcoming NEET examination, beta, you have a golden opportunity to revise once more. Just concise the topic. Any point, anything you are feeling uncomfortable, कि sir ये topic समझ में नहीं आया. Even we are conducting all these sessions so that you people should get the insight कि how to proceed in the upcoming days. Clear? I'm waiting for your queries, beta. Any point you want me to repeat? Thanks a lot, and thanks for awesome response in the chat box. All the compliments in the chat box, beta. Thanks a lot, and I wish you very best of luck. Work hard, and I'm waiting. You people will come for the interview. Best of luck for upcoming NEET examination. Thanks a lot, beta. We stop at this point.